there will be a lot of questions, I'm sure, directed towards the topic you just spoke to. Now, our next speaker is our leader in all things administrative, Professor Erwin Loh, Chief Medical Officer for the Royal Australian College of Medical Administrators.
I'm here to talk to you about VASM and RACMA. RACMA being the Royal Australasian College of Medical Administrators. I'm the chair of the Victorian State Branch. And my presentation is really specifically on how medical administrators like myself use audit data like VASM in their day-to-day practice. So RACMA was founded in 1967, which makes it one of the older specialist medical colleges around. It's not as old as RACS. RACS was founded in 1927, exactly 40 years beforehand. And RACS and RACMA have been long-standing partners for many, many years. Of interest, a few years ago, both RACS and RACMA updated their logos. RACMA runs a Leadership for Clinicians training program, and in 2009, which was the first time, RACMA and RACS did a joint workshop with 32 attendees, and was to look at how we can improve the relationship between surgeons and medical administrators into the future, both at an individual and on an organizational level. And it was highly successful, and I think we continue to work together on leadership programs as well. All of you know in 2015, RACS led the way in terms of revolutionizing the medical culture for our profession. We had an expert advisory group look at bullying and harassment and discrimination, came out with a whole series of findings and recommendations. And in 2016, RACS was a leader in health by developing and operating with respect program. I'm very proud to say that when I was Chief Medical Officer at Monash Health in 2016, we were the first health service to sign an MOU with RACS to create a positive culture in health. RACS and RACMA continue to collaborate. So just so you're aware, RACS, RACMA, St. Vincent's Health Australia, and Macquarie University, we're planning to have a joint conference in November of this year. It's been postponed to April of next year, 2021. It's called Creating Healthcare Cultures of Safety and Respect. And the idea was to bring together health leaders with a common goal to eliminate bullying, discrimination, harassment, and incivility in healthcare. So how do specialist medical administrators like myself use data, clinical data like the ones we get from VASM? So we know that minimizing unnecessary variation is one thing that will help to improve quality and patient safety. Now, that doesn't mean that individual practitioners can use their own clinical judgment to vary from clinical guidelines, but for most of the time, we have found, and research shows this, by minimizing unnecessary variation, we can actually improve care for our patients. And plenty of studies have shown this. This is something that the UK and the US are looking at. This is a report from the Sachs Institute in the US. And even in Australia, the Australian Commission on Safety and Quality in Healthcare have just released in June a user guide for the review of clinical variation in healthcare. So how do we actually do this? How do we look at clinical variation? So one thing is to track KPIs and to then benchmark the KPIs. So KPIs are basically key performance indicators or clinical indicators that are usually prospectively collected, most of the time automatically, that we can see on a scorecard that we track. So falls, pressure injuries is a good example. A lot of the hospital-acquired complications that we look at, readmission rates, post-op complications, SAP rates, and stuff are respectively, they're all KPIs that we can track, and we can look at variation. We can benchmark KPIs against state targets or against state or national key hospitals, and then we know if there is any variance from that. The other thing we can do are audits. So VASM, in one sense, is an audit, and audits are basically more manual than KPIs. You need people to kind of go in to do a review. They usually have checklists, and they compare what process or outcomes are against a particular benchmark. You can do a deep dive, obviously. You can do a more deep review of a service or a practice. And then last but not least, you can look at clinical registries. So VASM is, in one sense, a clinical registry. It's centrally held. It's a database of information that is curated, collected by people against a minimum data set, and it goes into a central database, which you can then draw reports out of. Clinical registries are fantastic. They're very useful. But one of the challenges is to actually make sure that they're integrated into the hospital reporting system. So I'm going to now talk quickly, refer quickly to the VASM information that we get from St. Vincent's to kind of demonstrate how, from a practical point of view, someone like myself, in a group level, so being a national chief medical officer, how I have an overview of surgical practice across the group. Now, bear in mind, although I have a national role, I've got public and private hospitals across the country. VASM specifically is for our Victorian hospitals. So St. Vincent's Hospital, Melbourne, a public hospital, and St. Vincent's Private Hospital, Melbourne, a private hospital. Main campus being in Fitzroy for our private hospital, where we do our campuses in East Melbourne Q, and also Werribee Hospital. I was back in Werribee Hospital, private hospital this morning. So this is our kind of total caseload, 216 in the public, 65 in the private. I'll just make one point, although I will be kind of looking at data and comparing the public hospital to the private. We can't actually do that because the case mix, the numbers, the volume is completely different. They're completely different hospitals. So the hospital, public hospital in Melbourne, it's a tertiary academic hospital, clearly, and VASM provides this. They provide state and national peer data to compare the public hospital with. Similarly, the private hospital will be compared with their own like state and national counterparts. But it is interesting to actually have looked at some of the data between public and private. A lot of our surgeons work across both. So this shows you the executive summary. I'm not going to go into each one in detail. You can see where, for the most, I think both our public and private hospitals in Melbourne do quite well compared to the state and national counterparts. I don't think we have massive variances. If anything, that is a variation we have identified, and we're working on it. I'll talk a bit more about that. So very quickly, just to show you some data, here we can see delay in surgical diagnosis, clearly an issue in our private hospital over the past couple of years, but it's come back to within normal range past financial year, which is great. The use of ICU and HDU does not seem to be an issue. Prophylaxis against DVT looks as though it was an issue for both public and private over the past couple of years, but has since come back to average, come back to the norm, which is good. Consultant surgeon in theatre, operating, assisting, and supervising. This is an interesting measure, something that I, as a group chief medical officer, has an interest in it. Has an interest in, and in fact, it's pleasing to see that we are not out of variation, or we're not different to other places in the country. Postop complications are here. You see unplanned return to theatre. Clearly, our private hospital is a bit above national and state averages, so something to look at. Unplanned admission to ICU, again, the private hospital for the past few years seems to have a higher number of unplanned admissions to ICU. Something to follow up. Unplanned readmissions looks to be an issue, or an emerging issue in the public and an issue in the private. Issues with fluid balance for both public and private looks to be potentially an issue, particularly in public, although we did kind of get it back to normal in the past year. And then you've got clinical significant infections. Those are the main characteristics of the audit. There's a screen here to compare both. As you can see, I won't go into detail, but we compare in terms of demographics and numbers pretty much well with our state and national counterparts. So what are the areas that we can improve on based on the data that we have received? So VTE, thromboprophylaxis is one area. It's something that we are already working on. But for example, our head of surgery, Simon Banting, at St. Vincent's Hospital in Melbourne, he gave a presentation at our quality and safety meeting for public hospital on the VASM data of the past 5 years. And that's one of the areas that he's identified as something that we're working on. And for a good reason, this is something that we are going to look at. Fluid balance, as I mentioned, is an area that we can also improve on. And also then our use of CCU. I'm not going to kind of like the percentages and the details. I'm just going to talk about things. What the areas that we seem to be doing well on, consultants in theater, right? And also then it looks as though we do quite well in identifying deteriorating patients and complications early to prevent them from progressing. And so that is good news. Now, what are some of the things that we have identified that VASM should look at to improve, or maybe, what are the known limitations of VASM in the first place? So these are areas, these are kind of concerns that our own surgeons have raised with me, and I thought I would share with you. So one of the things that we know about VASM data is that they're small numbers. It's the nature of audits and registries like this is that we rely on self-reported data, and the numbers of deaths in surgery, for good reason, because the care report is so good, the number of deaths are low. So, and because they're low numbers, in particular for some specialties, when you have deaths and when there are issues, the kind of graphing and the trends can be magnified. And so we need to take that into account. The other thing that we have noted is that we get the numerator of deaths, but we don't really know the true denominator. Because again, we rely on self-reported data. This is an issue for any self-reported quality registry like this. A good example is VASM data. So VASM is something that all hospitals use when it comes to looking at incidents and adverse events, but self-reported, and we get a number, like medication errors, but we don't actually know the true number of medication errors because we don't have the denominator. Same thing here. It's a limitation that we need to take into account. The other thing that we've noted is that all we get is mortality, because it's VASM by definition. We do not get morbidity information. So any near deaths, very serious complications are captured, but that's why we have M&M morbidity and mortality meeting reviews for all surgical units. In fact, all clinical units should do them. Feedback is provided to the individual surgeons, but some of the responses that I've received is that the feedback that they get can be a lot more specific. And clearly, some of the feedback is deliberately vague to not identify the individual practitioners, which may or may not be as helpful for employing hospitals. Which brings me to the last point, which I referred to. How do we ensure that data and reports provided by VASM gets properly integrated into hospitals' clinical governance framework, gets utilized by the hospital, and become part of the hospital's KPI and quality and safety scorecard, so that we close the loop, so that in any issues identified at an organizational level by VASM can be, people like myself who looks after hospitals can use it in a way that can identify the actual issue, and we can then close the loop to ensure that we protect our patients, improve our care, and address the concerns raised. So that's the challenge for any external quality registry or database like VASM, but it's something that clearly my college, RACMA, can continue to work with RACs to improve that relationship between medical managers and administrators like myself and surgeons and surgical groups like VASM, so that we can continue to improve our care for our patients. So I'll stop here now. If you have any questions or comments or suggestions, feel free to email them to me. Our email is on the screen. Thank you for your time.